All right, let's talk about a class of antibiotics that, well, it seems like every clinician has a pretty strong opinion on them. I'm talking about the fluoroquinolones. Today, we're really going to dig into the nitty-gritty, specifically with ciprofloxacin and norfloxacin. The goal here isn't just to understand what they do, but to figure out how we can use their incredible power without, getting burned by the consequences. This is all about precision, managing risk, and frankly, a huge amount of responsibility.
I love this quote because it just hits the nail on the head, doesn't it? It frames the whole issue perfectly. So think of fluoroquinolones like they're not your everyday diner coffee. They're that rare, incredibly potent single-origin bean. If you're an expert barista and you use it for just the right occasion, the result is absolutely brilliant. But what happens if you treat it like generic instant coffee? Use it carelessly for everything, you end up creating this bitter, really lasting problem. And it's not just a bad cup of coffee for one person, it affects the entire ecosystem. And that right there is the problem of resistance.
So right away, we're faced with this pharmacological paradox. On one hand, these drugs are absolutely essential. They're indispensable for some of the most serious infections we have to deal with. But on the other hand, you have antimicrobial stewardship programs targeting them and targeting them aggressively. So what gives? Well, it turns out the very thing that makes them so powerful, that really broad spectrum of activity, is the exact same thing that makes them a huge, massive driver of antibiotic resistance. Let's unpack that.
So here's where it gets really fascinating. You'd think two drugs from the same class would be pretty similar, right? Nope, not at all. And it all boils down to one thing: pharmacokinetics. Ciprofloxacin, this stuff gets everywhere. It achieves amazing systemic concentrations penetrating deep into tissues all over the body. That's exactly why we pull it out for those really severe, deep-seated, complicated infections. But then you have norfloxacin. It's almost the opposite. It's poorly absorbed, so it doesn't really get into the bloodstream at high levels. Instead, it concentrates like crazy in the urine. So its job? It's pretty much just for uncomplicated UTIs. The fight is happening right there in the bladder, and that's where norfloxacin shines.
Okay, so we've talked about the how. Now let's get into the where. Where does the power of a drug like ciprofloxacin actually get deployed in the real world? Let's shift from the theory and the pharmacology and get right into the clinic. We're going to look at the specific scenarios where this tool isn't just one of many options, but is often the absolute best choice we have.
Let's make this real. Let's ground it in a clinical case. So picture this. An adult patient walks into your clinic. They've got a high fever, really severe bloody diarrhea, and you're seeing clear signs of systemic toxicity. You get the cultures back, and it confirms what you suspected: a salmonella infection that has definitely gone way beyond a simple stomach bug. This is invasive salmonellosis. It's a life-threatening condition. And this is exactly the kind of battleground where you need ciprofloxacin, systemic reach, and its potent activity.
And look at how the dosing reflects just how serious this is. If the patient is stable enough to take pills, we hit it with 500 milligrams twice a day. But if they're more critical, if they're hospitalized, we're not taking any chances. We bypass the gut completely and go straight for the IV, 400 milligrams. We need to get those therapeutic concentrations in the blood immediately to get control of this thing. That choice, oral versus IV, it's a really key clinical decision.
And its use goes way, way beyond just salmonella. Just look at the range here. For gonorrhea, we hit it with a single, high-impact 500 milligram dose. The idea is to just overwhelm the bug, fast. Complicated UTIs, bacterial prostatitis, it's a go-to because, again, it gets right into those tissues where the infection is hiding. And then there's the big one, Pseudomonas aeruginosa, one of the toughest hospital pathogens out there. Cipro is a critical tool in our fight against it. So yeah, this isn't just a random list of diseases, it's really a strategic map of where this drug is absolutely crucial.
Okay, so for every single one of those powerful uses, there's a flip side. There's a corresponding set of risks that we have to weigh. We've seen the power, right? Now we have to look the dangers square in the face. And I'm not talking about just any old side effects here. We're talking about the potential for severe and sometimes permanent harm to our patients.
When you see this warning, you have to stop and pay attention. This isn't just some legal fine print. This is a black box warning from regulatory agencies. That's the most serious alert they can possibly issue. And those words, disabling and permanent, they were chosen very, very carefully. As a clinician, when you see this on a drug's profile, it has to fundamentally change your entire risk-benefit calculation for every single prescription.
So what does that black box warning actually cover? What are we talking about? Well, honestly, the most frightening ones are the events linked to collagen degradation. It turns out fluoroquinolones can actually damage connective tissue, and that can lead to catastrophic things like aortic dissections or leaky heart valves. You see, this isn't just a random collection of problems. There's a clear pattern here, a mechanism. And that's not all. On top of that, we see really severe photosensitivity, major disruption of the gut microbiome that can lead to C. diff or fungal infections, and of course the one everyone knows about, tendon ruptures.
So these serious risks, they translate directly into some very clear contraindications. Because of those concerns about cartilage and bone development, there are no-go in pregnancy, especially the second and third trimesters, and we generally avoid them in kids. Now, are they never used in pediatrics? No, for certain severe cases they are, but always with extreme caution. They're also excreted in breast milk, so using them during lactation is something you have to think very carefully about. And what about a patient with something like Marfan syndrome, a connective tissue disorder? Well, for them, the risk of an aortic dissection is even higher, which makes it a relative contraindication. And remember our friend Norfloxacin that's so dependent on the kidneys? If your patient has severe renal failure, it's absolutely 100% contraindicated.
You know, the risk to a single patient is a heavy enough burden to carry. But that's only half the story. Now we have to zoom out and look at the other half. The massive population-level threat that grows with every single prescription we write. I'm talking about antimicrobial resistance. This is the specter, the shadow that looms over every single decision we make with these drugs.
Okay, remember our case? The patient with severe salmonellosis? Now look at this number, 21%. In 2023, that's the percentage of salmonella isolates that had acquired resistance to ciprofloxacin. Let me put that another way. For 1 out of every 5 patients, just like the one we talked about, the powerful first-line drug we reached for would be completely useless. That is a truly terrifying clinical reality to be facing.
And believe it or not, that 21% number, as bad as it is, actually hides an even more dangerous truth. Resistance isn't spread out evenly. It's totally Cerevar specific. Just look at this. If your patient happens to have Salmonella Chester, there's an 81% chance that ciprofloxacin will fail. 81%. This kind of variability turns empiric therapy, treating before you have the culture results, into a really high-stakes gamble. You're basically betting against these staggering odds, just hoping you're right.
So you might be wondering, how does resistance get this bad this fast? Well, one of the key mechanisms involves things like these carbapenemeses. But here is the really crucial insight. The genes that give bacteria resistance to fluoroquinolones, they're often physically located on the same little mobile piece of DNA, a plasmid, as the genes that code for resistance to other major antibiotics, like our last resort carbapenems. So what does that mean? It means when you use a fluoroquinolone and you select for a bug that's resistant to it, you're not just getting that one resistance. You are unintentionally co-selecting for resistance to our most powerful last-line antibiotics. With a single prescription, you could be helping to create a multi-drug-resistant superbug.
So, wow. If the risks to our patients are this high, and the threat of resistance is this rampant, what do we do? How do we even move forward? Well, the answer isn't to just throw these drugs in the trash and never use them again. The answer is to master them. And the strategy for doing that is antimicrobial stewardship, with its single most important tactic, de-escalation.
This 3-step protocol, this needs to be second nature for all of us. It's simple. Step 1. For that really sick patient, yes, you start broad. Maybe you even use a fluoroquinolone to save their life. But, and this is a huge but, step 1 cannot happen without step 2. Get your cultures before that first dose goes in. Then, once the lab calls you back with the name of the bug and what it's susceptible to, you immediately execute step 3. You de-escalate. You switch to the smartest, most targeted narrow-spectrum antibiotic you can. That's how we preserve the power of the big guns for the next time we truly need them.
All right, we've covered a lot of ground here, haven't we? From the basic pharmacology to clinical practice, all the way to the societal crisis of resistance.
So, before we wrap this up, let's do a quick knowledge check to make sure a couple of the most critical points have really sunk in.
First question for you. Think back to that big, scary black box warning and the whole issue with connective tissue. What are two of the most serious, potentially permanent cardiovascular side effects that we link with fluoroquinolones? The answer is aortic dissection and mitral or aortic regurgitation. And that's exactly right. These are not your run-of-the-mill side effects. These are potentially life-altering catastrophes, and they're rooted directly in the drug's impact on collagen. Remembering that mechanistic link, that is absolutely key to prescribing safely.
Okay, question number 2. This one is all about patient safety. You have a pregnant patient. She needs prophylaxis for meningococcal disease. You know ciprofloxacin is one option for this, but you also know it's contraindicated in pregnancy. So what's the preferred agent? What do you use instead?
The answer you're looking for is ceftriaxone. It gives you that effective prophylaxis, but without any of the potential risk to fetal bone and cartilage development that ciprofloxacin carries. Knowing these safe alternatives for our vulnerable populations, well, it's simply non-negotiable.
And so, this brings us to one final, really provocative thought to leave you with. We started out calling these drugs a necessary evil in some ways, a powerful tool that you have to respect. But as resistance continues to climb, as it chips away at their effectiveness day by day, you have to ask yourself a really hard question. What happens when they stop being so necessary? At what point does the massive risk of breeding resistance for everybody outweigh the shrinking benefit for an individual patient? When does this necessary evil become simply evil? That is the question that I think every single one of us who prescribes has to wrestle with now.